by and large, obviously, when people have liver disease that's severe enough to require a transplant, it's not very subtle. People, when they get sick from liver disease, can have jaundice when their eyes turn yellow. They can have ascites when their abdomen feels full of fluid. They can have other complications of liver disease, confusion, which we call encephalopathy. There's a whole host of things that can sort of manifest severe liver disease. And, there's not one specific thing that sort of is a trigger that says the liver needs to be removed. When someone starts to have complications from their liver disease, like the ascites, the fluid, and the confusion, that's a sort of sign that the patient may be sick enough or to need a liver transplant and should be referred. There is something that we use within the United States to prioritize people on the wait list called the MELD score. The MELD score is a sort of formula based on someone's kidney function, their liver function, and their ability to produce clotting factors. And that is what's used to prioritize people, but it's not the perfect score. And there are people whose scores may be low. They may not be the highest priority on the wait list, but they are very sick and need a transplant. And those are some of the people who are almost best suited for living donation because, whereas the vast majority of transplants in the U.S. are from deceased donors, for those people whose scores are not high enough to, be the top of the list, but they need an organ, that's when living donation is really an ideal option because people are clearly sick enough to require a transplant, but may not meet this sort of score to put them near the top of the list where they would get an offer in the near future.
And what we like to tell the patients that come in for evaluation for liver transplantation that we'd rather not wait until they're super sick to have them transplanted, and that's what Living Donor provides. In order to get offered a deceased donor, often you have to get so sick in order to get a high score and get offered an organ, whereas we know that there are a lot of people who are sick that don't have that very high score and might not be able to get offered a deceased donor organ, but might have a living donor option. And this allows us the ability to do a transplant while that recipient is still at home. It can be done before they get super sick and have to be admitted to the hospital. It can be done electively. It can be scheduled. We can make sure we all, if they're, say their hepatitis is being treated, we can treat that and do the transplant after that's treated. But the outcomes in people who are not really sick actually are much better. They're less time in the hospital, less need to go to rehab, more active, less problems with their kidneys and things like that. So if you can transplant people before they get to that really sick stage, that's a bonus, and that's what Living Donor can offer.
Right. And the unfortunate truth is that sort of in the country, the demand for transplants outstrips the supply. And, even despite best efforts, there's still, maybe depending on where you are in the country, upwards of 20 to 25% of people will die waiting on the wait list for a liver transplant, which is why living donation sort of is a great option because if you have a living donor and you have a planned surgery, it sort of takes away that risk of dying waiting for a deceased donor, which is another benefit of living donation because, these, and they're showing numbers here. This is sort of data in our area, sort of our service area, which is sort of Philadelphia and surrounding areas, that show as of June 13th, 2014, there were nearly 700 people on the waiting list at the time. The number of transplants done over the course of the calendar year 2013 was 300, and probably about 35 to 50 people died waiting for a transplant, and that doesn't even count people that are removed because they're too sick. So those risks are real, and with living donation, sort of take away those risks.
That's the benefit of living donation, is that it decreases that chance of dying while waiting. Linda, you've been a pre-transplant coordinator for a long time, so you've seen both patients that had to wait for a deceased donor as well as those who got living donors, and there's
Yes.
a big difference.
There is. There's a tremendous difference. We actually had a question come through that was asking about the outcomes and how do the outcomes for living donation compare with deceased donor transplants. And I think that's a good thing to call out because the outcomes are actually a little better.
post-transplant survival, sort of how long someone lives after transplant, is higher among those who receive a living donor recipient versus a deceased donor, with the caveat being, though, that that living donor is performed at an experienced center, because it's well established that sort of centers that have not done living donations, from both the surgical expertise to sort of the whole team management, the outcomes are not as good. But when the living donor transplant is performed at an experienced center, there's actually a greater survival in those who receive a living donor, which is, up until now, a lot of the data had showed minimizing dying on the wait list if you got a living donor. But these are sort of, in the US, the first large-scale national data to clearly show that those who receive a living donor can live as long, and in certain circumstances, longer than those who get a deceased donor.
And the important part of experience, I think, has to be emphasized, because this is a tricky procedure, and it's not just the technical part. It's a technically complex surgical procedure, but it's also, I think, a lot of experience is needed in determining who can be a good donor and who can be a good recipient, and the judgment of when's the best time to do the transplant. And we did learn a lot. There was a learning curve when a lot of centers in the United States started doing these in the late 90s and early 2000s, and now there's a lot fewer centers who do it, because it's been recognized that you have to kind of do these on a regular basis, be experienced with them, and keep doing them in order to have excellent outcomes.